The preliminary information is just going to set the stage. We're focusing on the lower body. So the next class we will do will be, or not the lower, lower limb. And then it'll be the upper limb. The first one we did was the torso. You're going to see very quickly that you can't work with the legs without looking at the torso, but it gives us a way of chunking material up. The Massage Excellence course genre is set up so that you're going to have skill sets that you can hopefully will make your work more effective and more efficient. So try to give suggestions where you can use your body mechanics or something in a way that is going to make your life easier. So we're going to focus on these intervention areas. So SI joint is a big area when we look at this. And along with that, you get into sciatica or pseudo-sciatica, pelvis, making sure that there is some level of alignment in the pelvis. We also need to look at strains and sprains as an injury in a rehab. The itises and osises, the hip, knee are your most replaced joints. Because they're weight bearing, but also mobility. Knee pain is a big issue when we think about the lower limb. Plantar fasciitis, fasciosis. That we'll talk about it. It's not a lot massage can do with it, but there's some things that potentially we can think about, like making sure the calf is firing correctly and all of that. So that's kind of the sequence we're gonna, it may not be in that exact sequence, but those are the targeted areas we're gonna look at. The thing that gets forgotten in continuing education classes, I think, is that these targeted areas are embedded into the general massage. They're, if I were a physical therapist, and you've got an SI joint problem, then you might get something specific to the SI joint. We find ourselves in more of a supportive role around this. So you don't want to separate out a focal intervention from the general massage. You want to build that all together, and almost all of these can be addressed in the general massage process. You don't have to develop yourself into a real, there's so many names for muscle-skeletal alignment, or you're going to do this XYZ modality, or, and ongoing continuing education has a tendency to do that. They will carve out a narrow area, and I know why they do it. It's a time constraint thing. So I always want to make sure that you understand the wholeness of this and don't just go back and say, okay, now I don't have to do the general massage part of it. The general massage part of it is your assessment. It is the main focus of what your interventions will look like. Really, really good, thorough massage, from here down is going to address most of this with just a little tweak here and a little tweak there on stuff. So this next picture, can you see that? I want to make sure that
Yes.
Okay. This is from Joseph Schwartz. He did this a few years ago and put together a visual on the kinetic chain relationships. So if I'm thinking lower limb, I can't separate it out from the trunk specifically and the upper limb related to gait. So we've got diagonal patterns related to gait. We have got same side patterns related to balance. We have got stability patterns, deeper muscle stuff so that we can weight bear and move. We've got anterior stability patterns. And then we have our whole breathing torso patterns that go with this. You layer those on top of each other and there's your general massage focus. You don't want to separate those out. But when we're thinking, you know, if somebody comes in and they have got a groin strain, for example, or they're really tight in the medial part of their leg, or they've got knee pain on the medial side, working with that is okay, but if you don't connect your dots, the reason why they're putting strain on their knee may come from something up here. There might be a twist in the torso, or their shoulder might be rolled forward, and all of that is going to affect how you're going to land on your feet, which affects the chain coming up. So we're going to look at some general assessment that's going to target these walking patterns, and that'll be where our overlap will show up with the upper limb, lower limb. And of course, the torso, really the main focus you're looking at with the torso is that all of these movements, muscle structures, soft tissue structures, bony joint structures, have to attach to the torso. The torso, the main thing we really want to look at with torso specific is breathing. So when we work with those that were in the class previously, we talked about intrinsic muscles that had to do with breathing. So, but you have to go through all of the structures that attach the limbs to the body to get to the ones that are related to the breathing. So, you know, you can't ignore them. You've got to work your way down through it. So this is just a really nice conceptual idea. Joseph Schwartz, we've got some of his bigger posters hanging around.
You can get a laminated series of those on
And
Amazon. So
I think they
they're-
really help, and I think they really help clients. Say, this is why I'm working on your shoulder, even though you came in with your hip. So when we think about the lower limb specifically, and this is going to be just like with the upper limb, you've got a big bone, a big flat bone that is going to attach to the torso. And then you have a ball and socket joint, you have a long bone, you have primarily a hinge joint. The knee does have some rotation to it. Two bones that goes down to a connection to a platform. So in this instance, it's a foot. On the upper limb, it would be the hand. Vulnerable areas in the lower limb have to do with weight bearing, which is, in terms of what most people do in daily activities, there they are, is the hip, the knee, the weight of the upper body compresses these joints, and then down into the ankles and then the platform of the foot, the arch and platform of the foot. And when somebody ages, or their weight is such that they're carrying excess weight, you get more compression. And it is that reduction of joint space that in the hip and in the knee and into the ankles that causes you to lose space inside the joint. You get the rubbing. We can't do much with that. So as we get older too, the integrity of these tissues is not as springy, it's not as fluid filled, it's not as pliable as it used to be. So a lot of the time when we're working in this area, we're working with people that are older. You know, so we have to take that into account. Additionally, athletes, you know, or people, whether they're professional or amateur, or they're involved in some sort of like a boot camp exercise thing or some crazy thing like that. You know, all of the movement occurs in these jointed areas. So any repetitive movement of any kind, whether it's a job or anything else, it's gonna continue to rub these joints. So what we want to try to do, there's two things that happen with a joint. They're either too tight or they're too loose. So harder to handle, harder to manage is when you've got laxity in the joint. And starting to pay more attention to joint laxity syndromes, connective tissue disorders, hypermobility, that sort of thing. The way the body tries to provide stability, because stability has to be in play before mobility. So the joint itself doesn't have the ability to stiffen, or it can't contract, it can't actively do that. It can stiffen. The connective tissue can stiffen around it. It can swell, which provides some stability. But it can't actively do that. That's where the muscle connective tissue structures come in. So if you've got joint laxity, everything tries to tighten up around it almost like a cast. And one of the mistakes I see people do is they just assume that it is tight in there, but that what really is stiff and short and all that is protective around joint laxity, or it's trying to limit some movement or some position of the joint where there might be some wear and tear on the inside of the joint. So you got to discern the difference in that. And one of the main ways that you can do that is you work on an area. And if the person feels like they've got mobility, that's fine, that's good, that's what you want, less distress on movement. But if they feel a little worse the next day, you probably unsettled some compensation patterns that were resourceful. So one of the keys is don't do too much too quick. You know, if somebody is coming in with a hip issue or an SI joint issue or a knee issue or an ankle foot issue, you don't want to do everything all at once. You do a little and see, and a little and see. And as long as there's some level of progression, then you can, you know, be a little bit more aggressive over this period of time. As soon as you stabilize and you aren't seeing progression, you need to learn to be okay with that instead of continuing to try to get improvement, where improvement is actually going to mean that you're unsettling a compensation situation.
And recognizing too, a regional compensation will have systemic compensations, right? So there's the isolated part of it, but then how does that connect to the rest of the body? So throwing just your interventions at the region and not thinking about the systemic component and how it's all interconnected, that can be a reason for a person being sore and unsettled secondary. So, or returning really quickly, right? So thus why packaging any of this into the full body. Because no matter what, whether it be gait or other postural things, or even just from knee to ankle, right? There's always going to be something bigger than just the one area.
And again, partly in continuing education programs, partly because of the time constraints, you know, you narrow in on, let's learn how to do these 3 little moves, and then that's going to fix it. Well, it just isn't. It isn't like that. It's a process. And clients have to understand their new normal too. A car accident could do something, a fall. So you got just wear and tear. You've got some sort of inherent, you know, where your knees come in, or they bow out, or you've got laxity in your feet, or any number of things can come in and start to require you to seek stability. Almost always the compensation is seeking stability. Or it's seeking to limit movement a little bit because there's something inherently wrong with the joint structure. And joint-specific work is out of our scope of practice, but we can't, anything we do is going to affect the joint. And there are times when there actually needs to be some manipulation. The other thing that has occurred, which is especially good for those who have had a bad injury or aging, is that the joint replacements process is getting better and better and better, and they're improving the technology. The prostheses they put in are better than they used to be. They're making littler holes to do stuff. They're starting to do less invasive procedures, and if it is the joint, there isn't anything we're going to do with it other than manage some compensation, because if a little is good, then too much of it is going to be limiting for the person, that sort of thing. But don't discourage somebody from seeking good quality orthopedic type care. Now Luke as he's wandering around, he's the one that did so much pre-massage, post-massage after joint replacement surgery. And it does help people accommodate and adapt to that prosthesis. You got anything brilliant to say at this point on that?
The main principle being, thank you, that ideally we get people before, right? One thing I would say to encourage is if a person is beginning to consider finally getting the replacement. Our tendency tends to be we get a person beforehand, they're probably have dealt with the underlying arthritis for a while before it finally started inhibiting, you know, their daily activities to the point that they're actually seeking help. You know, they've gone through probably the traditional medical dynamic with physical therapy, and now it's become too much. And the recognition there being the joint isn't going to change. So you're limited in how much adaptability, and that's where the conversation can be. Well, yeah, that knee is, we got to get it as symptom-free as possible, but there's going to be a limited margin of how much we're going to increase, you know, beyond you deciding maybe one day to get a new one. But we can make sure the other knee and the rest of the body is compensating and not getting stressed as much as possible. And so, and I've seen every category within that, from like dual knee done at the same time to one and then the other, but and each have its issues. But like one person both knees are bad, they get only one done, then there's gonna be a lot of stress on the other one for a while. You know, there's always that piece. But I strongly suggest that you suggest that maybe they go get some pre-physical therapy before they go and do the actual surgery. You know, I might have some knowledge base of recommending exercises and what have you, but once the mobility is limited for long enough, the muscles that would perform said mobility are now, they may not be full atrophy, but they are going to be weakened, or they're going to have solidified in how they're interacting related to movement and stability based on that arthritic joint, right? So when they finally have the new one in, and the person has to go through the journey of now not just healing, but strengthening those muscles. And anybody that's had a client, right, that's the bigger journey, is that they're having to strengthen those muscles and get things wired again. And that's where we can do really good work. We'll be refining stuff with gait, as well as the firing pattern, muscle activation sequence stuff. We can really help that, but they need to be in some kind of, they need to commit to the exercise part of it, including physical therapy.
And that was really brilliant. That was profound. Okay. We don't see as much replacement in the upper limb. We see it in the lower limb with the knee and the hip. A lot of issues end up being at the feet or start at the feet. And we need to land on our feet in such a way that we don't evert or invert. We need to, because what that does is it strains the knee. And if the arch starts to collapse, or we are not heel striking and then going to our toe, or something like that occurs, that changes our posture. It changes the relationship at the SI joint, to, what we're doing here, and then we get shortening or tension around someplace else. So you don't want to ignore the feet, because it's like I say, it's either going to start there or it's going to end there. So plantar fasciitis or pain in the feet from like a bunion or corns or whatever, especially this accumulates as you get older, is going to make you try to not step on where it hurts. I got a friend right now who's older. She's my age. She had a traumatic break in the middle of her femur, which they pinned and put a post in it and all that kind of stuff. But it was about a year ago. She was walking on it protectively and some other stuff going on, developed a case of plantar fasciitis. And so then she was not wanting to come down on her foot. And then the last time I saw her, her knee was driving her nuts. So that's just another example of how we can't separate. You're shaking your head. You've seen that a million times. Yeah. So we don't want to forget the feet and the importance of ankle stability and mobility. So that's why this is here. And there's so many little bones in there. So there's all kinds of ligaments in there. And there's a lot of musculature, especially on the bottom of the foot. And a lot of connective tissue in through there. And tons of vessels. It's a lymphatic pump. Every time you step on your foot, you're compressing and letting go of the circulatory and fluid structure on the bottoms of the feet. So don't forget the tooties. So here's the other end of it with the pelvis. And a lot of the issue is going to land right here at the SI joint. And the SI joint is where the whole lower limb complex attaches to the torso. So the sacrum itself is part of the torso. The ilium is part of the limb. those two meet together just like that, a little bit at an angle, and there has to be a teeniest little bit of translation in there as we walk. There's this little bit of rocking that happens in there. It's weight bearing. It's weight bearing. That's why there's this little ledge that comes down and it hangs on that. And there's no direct muscular component. So when we're looking at stability and mobility, there's a couple of different kinds. And go forward here. There's form stability, which has to do with the shape of the bones and how they fit together like a pair of Legos. And then there's force closure stability. And this is where the fit is really loose. So soft tissue structures, fascia and muscles and ligaments and tendons have to hold the area together. So in the SI joint structure, it's a form closure. It's the way these bones are put together and how they're supposed to hang on each other and then have this little bit of a rock. If the pelvis is off, it's going to change the relationship there and things will get kind of stuck together. Usually there's instability in this joint, which allows it to get just, it's not out. You know, people say, oh, my SI joint's out. It's not out. It's just not lining up just right. And so you're going to get a lot of protective contracture on anything that tries to come into the pelvis to hold that stable. So that's a really key area that we need to focus on. The other key area is the actual shape of the hip joint. The ball here goes into a great big socket, and just like with the SI joint, it hangs on that. That's part of the weight bearing. But this is one of our more mobile joints. So there's also a lot of mobility that's required. The other one is the shoulder, which has very little form stability. It has to rely primarily on force, muscles and connective tissue and that sort of thing. But the depth of the socket is enough so that we can get some weight-bearing structure in through that. But when it does that, the joint starts to rub. The ball starts to rub on the structures of the socket. And then you start to get your arthritis and your arthrosis and that sort of thing on there. If the pelvis is set off just a little bit, or posture is set off a little bit, you also disturb the ideal way that this fits in here. So if this is like this, now when this moves, it bumps into it in the front or in the back. So there is something to be said for the pieces fitting together in a way that there's the right amount of space for the bones to move against each other, along with the stability so that things don't feel like they're going to fall apart. I'm all for flexibility, but I'm going to tell you, people who are real flexible have more soft tissue pain than people that are stiffer. And the idea that people should be able to bend over and touch the floor and bring their leg up around their necks. The things you see in yoga and some of these others is too extreme for most people. And they try to accommodate that if they're in a class or something, and they end up hurting themselves. So then another thing, just like Luke said, if somebody's going to get a joint surgery, they want to go into it healthy as possible. At the same time, if you're going to try to bring your structure into a place where your daily activities are as pain-free and fluid as possible, you have to educate your client about the balance between stability and mobility. People think the more mobile, the better. That's not true. That's not true. So, if we look here then, we're starting to layer on some other structures. This is your gluteal hip area. And there's 3 or 4 layers in there, and the main focus on any of these is to attach the leg itself to the torso. You also then will get, due to the ball and socket joint, you will get a multi-planar movement, which means it moves front and back sagittal, okay, which is a flexion and an extension. You get an abduction. Did I say that right? No.
AB,
Yes.
AB, yep.
AB away, and an adduction. And you get an internal and an external rotation, and you circle around with those with every movement that you make. So the way the direction that the fibers of the muscle go kind of tell you what it does. So these kind of go on a diagonal here, but this part has a little bit more of an up and down to it. So, and it's on the back, so it's probably involved with extension and some rotation. This group in here tends to go horizontal, so it's a spinner along with holding it in place. It's going to be involved with internal and external rotation. These are on the outside, the corresponding groups, the adductors on the inside. They're going to be involved, if you got a triangular shape to them, they're going to be involved more with abduction and adduction. Now that's functional, you know, and you can always look up what the actual name of the thing is. But if you look at how functionally it works, so one of the things that Luke and I focus on is you've got to work from surface to deep, and you need to go with the grain and across it. So you're sliding or moving that tissue in multiple directions. And a lot of times we do too much up and down and not enough across when we're doing the massage. The other thing to look at here, where the limb attaches to the torso, is nerves exit from the spinal column. And we got a big old one right here, the sciatic nerve, but we got a bunch of little ones. And anytime people get nerve pain in their glute or in their leg or whatever, they immediately, oh, I got sciatica. Lots of times it's not. It's not sciatica. You know, nerves are like worms. They don't like to be crowded. They want space. You know, and they need to slide around in there. And So reduced space on any of these is going to get you a grouchy nerve. So if it's really the sciatic nerve that is causing the symptomology, your pain pattern, nerve impingement has pretty specific patterns of pain that you can follow. It's going to be in the middle of your butt low, and it's go down your back, your leg, past your knee. Past your knee. If it's anything else other than that, it can be coming out of L4, L5 nerve root. It can be one of these others that comes down. A lot of times it comes down the side of the leg and into the kneecap. People think something's wrong with their knee, but it's that track of nerve grumping. And what you need to do is to try to get the pressure up off of that nerve.
If ever confused or looking for the charts, remember your dermatomes, because you can bring up the dermatome charts and have your clients look at it and they draw for you, and that gives you a pretty clear.
Yeah, where's this going?
Yeah.
Show me the track. If there's nerve impingement that's causing the symptomology, now you're going to get muscle change, contraction and stuff around it. They'll tend to draw a line. They'll give you a line. And that's why it's important in your assessment process that you ask the person, show me. Show me what hurts. Well, it doesn't hurt when I do this. But it hurts when I do, that. Can you put your hand on it? Well, it's kind of right here, and does it travel? Well, yeah, it goes, or it goes like this. As soon as they're doing this, I know it's not sciatica. So a lot of people are coming in and they're saying they got sciatic nerve pain, but they don't. And so the big thing on that is piriformis impingement syndrome. So they start digging around deep into the glute area underneath, destroying or attempting to destroy the piriformis, and inadvertently irritating the sciatic nerve that wasn't a problem to begin with. So we want to not think sciatic nerve first. How many clients have you had clients where they've come in and said, I got sciatic nerve pain? Yeah. And again, if it doesn't travel past the knee and it's more in the middle of the track, then it's probably something else.
And be prepared for a lot of people to be told they have piriformis syndrome. Okay, piriformis syndrome is when the nerve goes through the muscle. So, and there's a small subset of the population where that's true, but it's a phrase that's a little bit overused, and it might have something to do with the deep lateral hip rotators, but the idea that it's always piriformis' fault, think bigger than that.
Yeah, I saw you do this, Marie. Is that because people tell you that a lot?
Yeah, and the other doctors tell me.
Yeah, tons of doctors and chiropractors. It's a
They
really
say, yeah.
easy go-to.
Yeah, I'll tell you where the sciatic nerve does tend to get impinged, if that's the case, and it has to do with excessive sitting, is this muscle right here.
Quadratus femoris.
Femoris. And so, is this got legs on it?
Yes, everything has legs now.
I need a pelvis. I have one, but that's that now. So see, this is where all this would be. I'm going to sit. I'm compressing it as it comes out from the leg and down. So it comes out from the pelvis and down. Now, a place where, oh, she's got a real problem with the cerebellum. Is sitting on the toilet. will get that. Long periods of time reading. Who uses the bathroom, or do you know somebody uses the bathroom as the reading room? So, oh, we're not noticing that Laura's here. So, that muscle, when it's obviously going horizontal, which means that it has to do with internal or external rotation. And it also is positioned so it can do some abduction. So, that's right, adduction. Listen to Luke. It does this.
And at the hip.
Which muscle does that?
Quadratus
femoris.
Oh, the
femoris.
But, and all the deep lateral hip rotators
Yeah.
externally rotate, but it also pulls in, since it's so low, it can contribute to adduction.
Which
But-
the other ones really don't.
With the hips, you can always generally assume, in terms of concentric too short patterns, most people get stuck in flexion, external rotation, adduction.
Heidi, were you compressing your
Yeah,
quadratus?
it's hard to sit for a while. When you
There are-
sit for a while.
Don't,
We're-
or you can move around and
Yeah.
sit someplace else. So, I sorted this out a lot with basketball players and football players. They would get on one foot and then they would get this thing. They'd come in and they'd say, they have this thing. And that would get tight, and then there wasn't enough room. You know, anytime they would say, well, make it hurt. It was pinching on the sciatic nerve. Intermittent, you know, as soon as they got it so that it was in a more neutral position, then that stopped. So those are the things that aggravate that. That's more likely to be a culprit. The problem is, how do you get to it? And these days, I'm much more cautious about how I teach you to work around the pelvis because of the increased monitoring around inappropriate touch and that sort of thing. So I'm hesitant to, you know, I would have you, I'm going to show you how to do it, but I would have you work over clothing and all that kind of stuff just so that you're not accused of inappropriate touch as you're working higher up into the area.
In general, the times when you probably would need more like actual skin access is related to scar tissue. Okay, and that makes sense. The draping I suggest for that is not to do it in prone, but in sideline, because you can create a more isolated aspect there. Or refer. It's not like in PT they have access to cupping and all that stuff. And if they're already getting cupping in PT, which is more being incorporated than ever now, then you don't necessarily have to be the one that does it. Or you show a person how to do it, right? They get their own cupping set. You give them a clear understanding of how to do it safely and effectively, and you could avoid that if it's such a concern.
And in this one, you can teach them to sit on a ball.
Yeah.
And they can work in there and find out where it's at.
But in terms of working on this and the impression being, right, it's like anything, open palm and fingertips, you know, anybody here, this is going to be pretty commonplace. However, mostly illustrated for the camera, if I make sure how my forearm is oriented here, and this might be jumping ahead, but it's just a matter of keeping your hands out of the way. A lot of times when I'm down that low, because I'm trying to get here, right? So I'll come around so that the view can be seen better. But I have to work up here for the glutes. But when I'm down this low, you know, I could be actually contacting their leg with my hand, and they have a clear sense of where I am and it's my forearm. And sometimes if I'm elbowy, just because of how small of this space is, I do have to be a little bit sharper just to get contact in there. But all it really turns into is being sure that as you work in this area, and I'm a bit more prone to working on it and prone, is thinking those glute muscles that we looked at. And then as you work your way down through these deep lateral hip rotators, remembering that quadratus femoris exists, it's all the way down here. So the pattern has to be, as you're going through and being more thorough, this model will show it. There. So there's quadratus femoris. And look how comparatively low down that is. A lot of times people think they'll pretty much be more focusing on piriformis, and we learn that that's just 1 out of 6 here. So the mechanics of that are just, not only am I here, I gotta make sure I work my way to the point where that greater trochanter, I want my elbow to be past it. I wanna be inferior to it, just a bit. And then the thing you do here is if we take the leg into, so I have all these models, if I take that joint, this is the opposite leg. No, it's the same leg, we're good. If I take it into external rotation, that trochanter rolls up into me, and that space becomes smaller. It's more uncomfortable for the client, because it's just gonna be bone on bone, right? Now, these muscles though, when they shorten, they externally rotate, or laterally rotate. So if I wanna stretch those or lengthen them, it's gonna be internal hip rotation, but what that does for me is it actually opens that space up. So working here, I do sometimes have to watch with my body mechanics, I'm not getting too twisted, but I'm trying to do this. I'm holding here and I'm pulling the leg outward, creating internal rotation. And just body mechanics wise, that's what you have to watch, is as you're doing that, not getting too twisted.
So this is one of the areas that we'll actually practice, because it's not something that you do. Most people know how to get into the deep lateral hip rotators. So when I pick out the things to practice, I want to pick out things that you don't already know how to do, right? Or you're uncomfortable doing it or whatever. So as we move down the leg then, we've got muscles that are shaped like triangles, and you can assume then that they're primarily going to be adductors if they're in the medial side. They're going to be abductors if they're on the lateral side. And these muscles are about balance. We don't spend our life walking around like this, right? Unless there's dance performances and stuff. But we spend a lot of time like this. Every time you take a step, you're on one foot. So this leg has got to have stability. And so the adductor muscle group is really a big player in that. So now we're starting to get into some of the misconceptions again, when people will say, my adductors are really tight, my hamstrings are really short. Maybe, maybe not. These muscles are hard to get to if you only use prone and supine positioning. They're easy to get to if you use sideline. So that's an example of positioning makes your life a whole lot easier.
And focus on forearm, because inner thigh contact, another factor to be just mildly cautious. And so we'll work on showing a little bit like how I did there, just how we can do this with effective biomechanics, but also limiting any kind of, perceived strangeness.
When we get to the thigh here, there's one big bone in the middle, and then it's surrounded with tissue. And those tissues, those muscles and fascia and all that, they're divided into compartments. So, and those compartments have a function together. So, in general, you work more in the compartment structure of muscles, the group, rather than the individual muscle. You can't get to an individual muscle. I don't care what anybody tells you. Maybe you can get to one up here, but I don't know. It's frustrating to me that when you have to challenge that licensing exam, that NBLEX exam, for example, that they want you to say, they want you to identify individual muscles. You know, a person does this, what muscle caused that? Well, it can be part of a group that caused it. So I always get into conflict when I have to teach this because I know what you're going to encounter, but it's not true. So once you pass that and you're in practice, don't focus so much on understanding an individual muscle. Look at what are the hip flexors. That's a group. What are the knee extensors? That's a group. What are the knee flexors? That's a group. What are the hip adductors? What are the hip abductors? So here you can see there's a little compartment right here. That's your whole quadricep group, all the different names of it. But they're positioned to flex at the hip. They also function down here at the knee, so this group's got a split personality. It has to flex the hip, but it also is involved with the knee. If it's on the inside, it's going to pull in. If it's on the outside, it's going to pull out. If it's on the back, it's going to pull this way, except that group also has to, so it extends the hip, but it also flexes the knee. So when we do massage, we think about how do I make sure that these groups can function independently? Because a lot of times in the groove area here, they'll get a little hung up. They won't be they won't slide very well in there.
Particularly with limited mobility. So somebody has a knee or a hip issue, they're not moving that tissue enough to keep the lubricating fluids dispersed evenly in there. So that's where if you can just look at those lines of where these compartments overlap, that's where we can do really effective work. Think on a myofascial perspective, but maybe I'm not trying to change the deep fascia, I'm trying to make sure the fascia between the anterior group and the medial group are lubricated. And we do that by squashing it and going back and forth in lots of directions so that fluid gets squished all over the place.
This is the anterior leg, and there isn't much up there. Now this is its main job is to pull the toe up so that you don't trip over it, like I tend to do. But it's firmly attached up and down the bone there. And of course it all goes, this is what happens once we get down to the platform area, whether it's the hand or foot, it goes down into tendon structures, which are a more passive structure. So if somebody has got something going on here, I got to go up to where something can actually pull. So if somebody's complaining about their ankle, I'm up in here somewhere where I've got the belly of a muscle to work with. This, because it's firmly attached to the bone in through here, and there's a membrane between the fibula and the tibia. That's where, if there is repetitive movement in there, you'll get some inflammation. They'll call that a shin splint. If that's up here on the tibial tuberosity right here, this big bump on your knee here, that can act like a tendonitis. So, but these muscles don't have anything that goes on a diagonal or lateral, doesn't have a lot of movement. This one does. This one is the main one that will pull up.
So someone that has dropped foot, is that mainly a nerve?
Yeah,
related
it's a
thing?
nerve. Yeah, that's a rough one. You'll see that with stroke a lot, and that's coming more from up here, but I worked with people that have strained or stretched or pulled the nerves that come down through there, and then they can't lift their foot. So these can become weakened, because if you can't get your toe up, you're gonna trip over it. And as we get older, falls are a big issue. So it is important that that's strong enough to pull that toe up. As well as the ones we're looking at now, that the unique thing that people also forget is that the gastrocnemius can be a knee flexor. And if the hamstrings are not functioning at the knee like they're supposed to, because there might be an interaction with it in its flexion extension movement, gastrocnemius will jump in to do it. And the symptom, gastrocnemius, comes up and hooks onto these two bumps.
It's the muscle that actually
And then,
resides on the posterior part of the leg, so the posterior knee issues. I would like to think everybody here's, maybe the beginners aren't there, but then you have popliteus hiding underneath that, of course, too. But it's gastroc that's really posterior to the knee. The hamstrings split and either go over onto the fibular head, or they come over into this crazy intersection. Do you have a slide on the pes anserine? I'm already saying it, so whatever. But the pes anserine, sometimes called the goose foot, though I don't really know if that's very as common. This
There it is.
is a place, right down there. This is a place for a common tendonitis as well. So strange one in that it's where sartorius, which is a hip flexor, external hip rotator, and knee flexor. So sartorius is an interesting one. It attaches there, down on the medial side of the tibia. Gracilis, one of your adductors, attaches there, and semitendinosus and membranosus. I think it's usually stated as tendinosis, but I just assume it's both. But what a crazy intersection. And how if something is gummed up here, how that's then going to affect an anterior hip thing, a medial hip thing, and a posterior hip thing, as well as a knee thing. So I don't necessarily have to dig on that, is the challenge, okay? Sometimes for counter irritation, maybe, I need to be sure I get this line, this whole crazy, I mean, you look at all those strands coming down together, right?
Yeah.
So the musculotendinous junctions, when you're ever looking at this, we want to make sure we do occasionally try to pay attention, is where the white turns into the red. So I want to try to go across that. And how do I do that? Sideline.
yeah, yeah. So the gastrocnemius, the calf, that we think of, is the one that works at the knee, and then underneath it is the soleus, that is the big plantar flexor. Those have to have a little bit of slide on each other, and a lot of times they don't. And so you can get ankle limitations, and or you can get problems at the knee.